Welcome to a Perspective Roundtable from the New England Journal of Medicine. I'm Atul Gawande. I'm a surgeon at Brigham and Women's Hospital and a professor at the Harvard School of Public Health and Harvard Medical School. The enormous cost of healthcare in the United States, driven by technological advances, the fee-for-service payment system, and increasing patient demands, among other factors, has inspired new efforts to assess the true value, or the cost-benefit ratio, of our commonly provided services. When a service is widely recognized as providing little or no benefit, or maybe even harm, what should be done to reduce its use? How can physicians work with patients to make appropriate choices when the value of a given intervention is in doubt? Here to discuss these issues with me are Carrie Colla, Assistant Professor at the Dartmouth Institute of Health Policy and Clinical Practice at Geisel Medical School, Scott Halpern, Assistant Professor of Medicine, Epidemiology, and Medical Ethics, as well as Health Policy. He's also a critical care physician at the University of Pennsylvania. And Bruce Landon, Professor of Healthcare Policy and Medicine at Harvard Medical School and a primary care physician at Beth Israel Deaconess Medical Center. I wanted to start with a seemingly simple question. How do you define low-value care?
It turns out that there are very, very few services that are low value in all clinical situations. So I actually think it's really important to use a clinical lens, and particularly for, as I'm taking care of patients, it's a lens that really focuses on that patient in front of me. When I'm thinking about my patients, I focus much more on the benefit side than, for instance, the cost side. So I found in a clinical interaction and even in pursuing patient care, it's hard to sort of take that step back to the health policy person and say, this might not be worth the money. But it's actually relatively easy to say, I don't think this is going to help you very much. And in fact, not only might it not help you, but it might hurt you because the consequences of doing this test are X, Y, and Z.
Well, I think you mentioned some terms that can be brought into defining low-value care, such as risks, risk of harm versus benefits. And I think there's a number of different instances for a given healthcare service to think about in terms of its profile, such as what's the certainty of benefit, what's the size of the benefit, what's the level of the cost if a procedure is expensive or inexpensive, and additionally, what are the alternative options that are available are all important to think about in thinking about the definition of low-value care and perhaps different categories of low-value care.
Well, I think it's incredibly difficult to draw lines, particularly because all our definitions are predicated at the population level. And population level estimates don't apply very naturally to individual patients. So when we describe something as low value, I think what we're typically trying to do is to distinguish it from something that is no value. But it turns out that no value interventions, first of all, are probably very few and far between. There are very few things we do in medicine that truly could not help any patient to which we might consider applying it. Whereas low-value interventions are probably just a notch above, and then there's a much broader net of interventions, tests, services, therapies, for which we could provide to lots of patients or relatively few patients. And how carefully we target the patients to which they may benefit will determine the relative value.
Well, let me try with a case where there is some clear evidence and wide agreement that a service or a practice we provide is of low value, and yet physicians aren't stopping providing it. In fact, it's arguably of no value. For instance, preoperative testing for a healthy 75-year-old woman who has no history of bleeding in prior surgical procedures, and she is now scheduled to undergo cataract surgery. It's one of the few areas in which we actually have randomized testing. The randomized testing has led to recommendations from the major specialty societies, including the American Academy of Ophthalmology, the Society of General Internal Medicine, that we should not perform preoperative medical tests for eye surgery unless there are specific medical indications. However, we've seen that the likelihood that people are providing this service has been climbing over time, even since then. Who is responsible for trying to make a change in something that has cost and arguably no value?
I think it's going to be hard to address the problem of low-value care by having payers and policymakers make rules, because there's this clinical heterogeneity story. And so, for instance, you're not going to know someone's having unstable angina necessarily when you prohibit preoperative testing for low-risk people. So you really need to sort of have a clinically nuanced approach, which is difficult to do through payer-based rules or broader policies. So then that sort of turns us on. So how do we get the system to respond? How do we get physicians to respond? As we sort of are starting to move with policies toward changing around the incentives and the payment systems, accountable care organizations, global payment policies, that actually gives incentives to providers and provider systems to say, where is the low value stuff that we can cut out? Because that's how the patients will do better and we will do better. And when you start turning the onus on physicians and physician organizations, I think that will get more traction.
The Choosing Wisely campaign tells a very nice story. The Choosing Wisely campaign was established by the American Board of Internal Medicine Foundation. These are lists of 5 things that are physician-driven, professional society endorsed services, tests, procedures, other interventions that patients and physicians should question. There are now upwards of 60 lists that, totaling 300 or more recommendations of services that tend to be utilized in common practice, but for which the value is not deemed to be high for sure and may in fact be negative. In fact, the harms outweigh the benefits. Physicians for a long time have had guidelines to recommend that we should be utilizing high-value services, but we haven't had clear guidelines as to what low-value services look like. So now we have that roadmap. But I think what's potentially more important is that this is a sea change in that physicians are taking the lead in reining in the costs of their own care. And we tend to do a bit better when we are taking the lead on something than when we are following recommendations or heavier-handed interventions still that we don't control.
So there is some role for physician autonomy when instead of a payer giving an approach for coverage decisions or benefit design, rather letting the physician group make the decisions under a broader global payment with outcomes monitoring or something like that. It takes the onus of payment policy going down to the minutia of nuanced decisions about measures, being able to stratify across different risk groups of patients. So for example, even the ophthalmology recommendation, they give, I think, at least 4 exceptions to their rule in their recommendation. And so I don't think we've shown in the past that we're able to do quality measure in a nuanced, stratified way and update it frequently enough to be in conjunction with as evidence moves forward.
Let's consider a case where the service is of low value and the physician may find it easier to order the test or to provide the service than it is to try to explain why they wouldn't do it.
There are certain things that we could think about doing that might make it somewhat easier. First, we can build on norms. We can set norms and expectations for how we do practice medicine, explain in a very transparent way the reasons behind our decisions. And there's a fair bit of evidence, in fact, that when transparency is augmented in those ways, patients tend to accept physicians' decisions even around such tricky situations as, this is a reason I can't give you the influenza vaccination. Other things that we might consider would be to change the ways in which we deliver care, to change the length of our clinic hours or the lengths of our shifts on the inpatient rotations, because there's this concept of decision fatigue that sets in. The more decisions we make, the more we're likely to make the easier choice the next time.
Some of these conversations are easier than other ones. One where this is much more difficult, for instance, is prostate cancer screening. So prostate cancer screening, the PSA test, which is now a U.S. Preventive Services Task Force grade D recommendation. So C means we should have a conversation about it, and that's what it was up until a couple of years ago. D means essentially do not do. And I actually have I have my spiel. I say the best data are that if we screen 1,000 men for 10 years, we'll probably save 1 of them from dying from prostate cancer, with the death rate going from 5 per 1,000 to 4 per 1,000, at a cost of treating 30 to 50 of them for prostate cancer with total prostatectomies or radiation therapy, both of which are very commonly associated with incontinence and impotence, lots of side effects that really make your life difficult. And then I sort of say, you know, on the whole, you're doing all that harm to get very little benefit. Given that, what do you think you want to do? And I'd say 2 out of 3 of my patients say, let's wait till we have a better test. But there's still some portion of them who say, you know, we've been doing this test for 10 years and it's just a blood test, I'd like to do it. And then I actually think sort of having this external validation to bring it. So I start that conversation with the U.S. Preventive Services Task Force has said. And it's very nice to be able to fall back on sort of these national organizations because, you know, to really give the sense that you're doing this based on what you're supposed to be doing, not for some other reason.
When overuse is driven by patient requests or demands, what do you think is the best way for individual physicians in the healthcare systems to tackle those requests?
I think there are certain circumstances where patients have strong preferences to receive something that physicians may not think is appropriate, but I actually believe that those are the exceptions rather than the rules. That typically when patients are making what we might easily or naturally perceive as requests, they're more requests for more information and often requests for guidance. And we can use that as an invitation to frame choices in mindful ways that can foreseeably nudge patients towards making certain choices together with us.
Carrie, does that correlate with what you understand? How big is the patient push for services versus the provider-driven?
I think it depends on the service. Each service kind of has its own profile. Where's the push coming from? Who's ordering it? What's the cost to the patient in terms of time or other risks or other costs? And I think it really varies across the different services that we're talking about quite a bit, the patient's role. Value-based insurance design, that's a way to bring sort of the more societal level cost down to the patient level and get them to sort of internalize the costs. But some research has shown that patients aren't necessarily good at making those trade-offs in all circumstances.
There's not a lot of low-hanging fruit in terms of designing those benefits. So everyone has tiered formularies now. Before we had tiered formularies, when I had a discussion with a patient about, you know, you're on brand name medicine X, but it turns out there's a generic, and you know, I believe the science that the generic is as effective as the brand name, and I can't tell you the amount of pushback there was. As soon as the discussion changed to being, you can get this generic for $5 a month, and it's going to be $50 a month if you want to continue your tier 3 brand name medication, I almost never have those conversations anymore. So that was an example where value-based insurance design works tremendously well. The stuff that we're generally talking about here, it doesn't work that well. So for instance, MRI of the back. So you could say MRIs of the back, you know, are very low value, which they generally are for back pain. You know, every guideline you can look at says we should wait on it, yet, you know, we've done some research showing that rates of ordering MRIs for visits from back pain have doubled in the last decade. Very clearly low value. So does that mean that we make all MRIs something with a high copayment or high deductible? Well, it turns out there are lots of MRIs that are useful. And even if we talk about MRIs of the back, I mean, the person with routine low back pain, very low value. My patient who had an epidural abscess, very high value. And it's hard to write the rule, it's hard to write a benefit where you can take into account that extent of clinical nuance and differences.
It's a puzzle what we end up doing when you get to really borderline difficult cases where you're really forced to have these decisions, no matter what the decision fatigue is.
The right rates at which we utilize these quote-unquote low-value services is not zero. We don't want to practice so frugally that we're missing opportunities to provide benefits to patients by not intervening. So I think at some level physicians should be comfortable that they can make clearly well thought out choices that, although there are recommendations not to do things for the overwhelming majority of patients who fit a particular description, that there may be exceptions where the service is in fact a reasonable choice. Now, how do we get physicians to reduce rates from what might be the current status quo is a tricky question. One thing that I've been thinking about is whether we could allow physicians to sort of set the bar themselves and determine the national average. For example, if we publicize the target rate for preoperative evaluations as being 10%, then it may be that physicians' own percentages might differ a little bit from that 10% benchmark, but that we would only confer penalties in the form of withholding fees if physicians were dramatic outliers above that mark. And I wonder if that could really rein in some of the practices that are sort of driving the overutilization.
My concern in terms of like having a measure is the measures are rarely going to be pristine. But let's say you're in an organization where they have a lot of prepaid care or global payment, and I can look at my physicians and I notice, Dr. X over here seems to be getting 3 times as many, stress tests before intermediate risk surgery as Dr. Y over there. Let's have a discussion together. Maybe look at some of those charts. Show him the data, how he compares to his colleagues, and let's see if we can use some more, peer pressure, some feedback that's sort of more pertinent and germane to change their behaviors. And I see that as there being, some potential.
Can we apply some of the things we've learned in the quality improvement efforts over the last 20 years to the overuse case? And, would feedback work? Will clinical decision support work? Other things. And we don't really know yet whether those things will work in the case of low-value services, and I think that's one of the things we need to learn.
I can imagine the counter-argument being, well, we will provide these measures, we'll provide transparency, we'll put incentives in that push in the opposite directions. What's your level of worry that we're going to end up denying people high-value care?
I think that there's a danger that blunt payment instruments will reduce the high-value care as well. And so I think to some extent that's why thinking about it at a broader level while also monitoring outcomes, but thinking about it at a broader level in terms of payments makes more sense.
There may be more to be gained by changing the culture of medical practice, changing the ethos at a very early level, from medical school on, where we're now trying to train physicians to recognize that they actually have 2 fundamental purposes: the well-being of the patient in front of them, as well as the well-being of all potential patients. And if that ethos is internalized and physicians are allowed some discretion that they've traditionally grown up with to make individualized choices, it strikes me that we might make a fair bit of progress on reducing overutilization without running the same risks of misappropriately denying services when they would in fact be beneficial.
And there's other tools that we have available. In new payment and incentive designs under global payment, we're seeing much more robust use of quality measures. The quality measures aren't great, but they almost always include things you're supposed to do or not do, as well as patient experiences. So at least making sort of a statement that we care about the outcomes as well. So we're putting organizations on global payment systems, but we should never put doctors on global payment systems. So you should never be in a position where you have to think, oh, if I order this MRI, I'm going to pay $3,000 out of my pocket. It's always got to be sort of, a group issue that's going on. And we also have to rely on the inherent professionalism within medicine. At the end of the day, we're taking care of patients. We need to do what's right by our patients. Even if something ends up on one of these low-value lists, sometimes it's going to be high value. If we believe that as physicians, that's something we need to make happen.
You talked about measurement particularly, and I think not just measurement of healthcare services, but measurement of things like shared decision-making quality. There's a lot of research going on in that area right now. How do you measure the quality of a decision made between a patient and a doctor? And so bringing in some of those metrics also under a global budget will help.
One part of this we haven't considered are the systems that are bearing down on the patient. It feels like the biggest change that I'm at least perceiving in my practice is the rise of limited networks and very high deductibles and high out-of-pocket expenses of other forms. And in low-value care, you're starting to see people use terms like financial harm of physician decision-making and financial toxicity. What are you noticing, Carrie, in the literature around what happens when people face $5,000 deductibles?
Well, I think this area of research is still very much in the works, but research has shown so far that patients don't necessarily make good decisions between high value and low value care.
What do you think the physician's responsibility is, Scott, for informing the patient, and or even just knowing themselves what level of financial harm they may be inflicting on someone with a low value service?
The information that we need to be good guiders for our patients is often not readily accessible for us when it comes to cost. If it were, then I think it would be easy to say that that could be part of our responsibility in shared decision making. I also worry a little bit about the solution to this problem of physician overutilization being to raise the costs to patients. And there are a couple reasons to be a little bit wary of such a solution. One is there's a nice study that showed that as patients' co-pays for medications went up, their use of prescription drugs in fact went down, as you would predict, but their rates of visiting the emergency room and being admitted to the hospital also went up. Additionally, those costs then are accruing to people in very different ways, and it may be the least well off to begin with who bear the biggest brunt of the adverse outcomes.
I don't always know the costs, although I get a sense from my patients. And usually what will happen is, the first time you sort of go through this with a patient and you order some testing, monitor their diabetes and whatnot, it goes okay. But then the next time they come in and they show you the bill and say, can we talk about what we need to do today? And there's a negotiation that comes on. You have diabetes, you haven't had your hemoglobin A1C checked in a year, you really need to have that. But potentially we don't have to do, check your kidney function today, and we'll do that next time. And frankly, I think that high deductible health plans are actually much harder for things that we need to do as opposed to things we're trying not to do. So it's a lot easier to have that, let's not get the back MRI discussion today when the patient might have to pay $3,000 for it out of pocket than it is when they pay a $10 copay. So sometimes it does go along with us, particularly for services that we think are low value. It's really, the problem is, are we going to affect the things that aren't so low value, or where we're not sure?
If we don't have the information to provide to patients, and if they don't have it readily accessible to them, then the information upon which they're making these risk, benefit, cost decisions is suboptimal. I also feel like that we can make a lot of headway if we simply make it less easy to order, to use. So if we had plenty of MRI machines in this country rather than an overabundance of MRI machines, I think our temptations to order MRIs would go down because it would be a burden for our patients. They'd have to wait for this test. They'd feed that information back to us, and we may be less likely to order it the next time.
Well, I think one of the things that you both mentioned is time and ability, right? So it's different if you're trying to decide right now in the visit whether or not to order something, whereas if you have time afterward where you can think about where's the best place to get the test. Like some tests have very different prices depending on where you go, and some insurers are starting to call patients and say, you're lined up to get this test done at hospital X, but if you go to hospital Y, you'll save $2,000 on the price, and $200 of that is out of your pocket, or whatever it may be if you're under your deductible. So I think having time for either the doctor to gather that information or for the patient to gather that information could be helpful. I don't think it's impossible going forward that information could be more readily available.
What would you say that the policies of the government ought to be, or of insurers ought to be, in order to make shared decision-making more effective for both patients and physicians under these circumstances?
If we had one health insurance coverage system, all the prices would be a lot easier to keep track of for physicians and patients alike. And it would be much easier to have a set menu at the bedside as these conversations are unfolding of all the types of information that we would want. I recognize that may be a long way away, but it is one of the sort of unintended consequences of our variegated reimbursement system as it exists today.
Another alternative might be in the alternative quality contract, for example, in Massachusetts, that Blue Cross Blue Shield ran one of the first ACO programs. One of the results that we saw in the research was that it changed referral networks, referral patterns. The researchers found that doctors started to send their patients to lower priced services, for example, for imaging.
There's a big tension that comes up, particularly among us sort of academics, medical center-based physicians. The issue of imaging is an easy one. So if you were going to get an MRI at my institution, it might be $3,000. It actually might be double at your institution. You can go down the street to Shields MRI and get what I am told is a perfectly good and well-interpreted MRI for about $500. And so people think, doctors under global payment contracts, patients under high deductible health plans, should I be doing that? But as a physician, I hate that, because right now I have this terrific electronic medical record where every x-ray that I've ordered or MRI that's been done in my system, I can pull it up, I can look at it, I can make comparisons, I can get opinions. The orthopedist I'm going to send the patient to can look at it, all those sorts of things. That one at Shields is unavailable to me unless the patient actually gets a disc of it and brings it in, it gets read in, at a loss to our radiology department and gets in that way. But until we have sort of better information exchange, there's this big tension between, is it worth the cheaper price, what you give up in your ability to coordinate and manage and communicate?
But arguably, the suggestion that's sort of emerging out of this is that that decision should really be a shared decision between you and your patient with the information in front of you.
I don't think we should leave this conversation thinking that shared decision-making is the road away from this quagmire that we're in. I think there's a very clear role for shared decision-making. Treatments like treatment of, surgical treatment of back pain, treatment of prostate cancer, where there's actually a lot of the patient's values that go into, do you value your life 10 years from now more than now? How much do you value the chance of incontinence or impotence or whatever? Those are very important things to have shared decision-making. There are a lot of decisions, though, that I think I face as a physician where the patient looks at me and says, Doc, you're the expert. I really want to know what you think. I'm going to have to pay for this test. Is it worthwhile for me to get the test? We see patients all the time where they're having some sort of chest discomfort. They have some risk factors for heart disease. You think it's probably not anginal or an anginal equivalent, but it could be. And often, if we're worried enough, we order stress tests. If it rose above my threshold where I think someone needed that test, I would hate to then have the patient say, oh, that's going to cost $400. Can't we just do away with it? So if it's something where we as a physician or I as a physician think it's really clinically indicated, I'm hoping we'll have other mechanisms where we're not relying on just looking at that price.
We've managed to cover a lot of ground around low-value care, and what do you think are the important lessons to be drawn from that discussion?
I think the real legacy of efforts like the Choosing Wisely campaign will not be to demarcate items that we should do less, and the real lessons of reimbursement reform that are intrinsically going to be tied to specific interventions. Similarly, I think, may not be the direct consequences of reducing utilization of those specific interventions, but rather creating a new culture of practicing medicine in which we remove our traditional taboos against discussing costs and attempting to constrain them. And doing this collaboratively with patients and doing it in a transparent manner where we prioritize our responsibilities as shepherds of scarce social resources to the same extent that we've historically prioritized our responsibilities for providing benefit to our specific patients.
I agree. I think the Choosing Wisely program, along with the U.S. Preventive Services Task Force, has moved the dialogue in a different way in the last few years. There's a lot more public discussion around a lot of these things, which I think will be useful. As an economist, one of the things I think about is, from a policy perspective, we can only use payment incentives where we think we have really good measurement, and I think measurement in this area has a long way to go. And so ratcheting down with payment incentives in this area, I don't think on specific items will be useful in the short term. But thinking about what's the right level for policy to intervene to make optimal social choices in a sense.
I think there's a much broader recognition societally that we're spending too much on healthcare, and that it's coming at the expense of doing things like hiring more teachers, hiring more police officers, rebuilding our schools, rebuilding our infrastructure. And so in that setting, when we're actually now having tools that are coming about that are going to help us with these decisions as providers, an increasing recognition that this is part of our job as physicians, as part of our professional responsibility. We're seeing the payment reforms that are going to support this sort of work, things like choosing wisely, highlighting that it's okay to start looking for and thinking about what services are actually hurting people. Where do we see low value, and trying to eliminate it. So any movements in that direction, I think, are going to be useful and frankly necessary as we try to sort of grapple with all this as a country.